Okay, good morning. Today we will have a ward round scenario discussion. This will be presented by Dr. Anish, who is third year junior resident at RKM Shareposition, Vivekananda Medical Sciences. Professor Oimunnu Basu, Professor and Head of Surgery at IPG SSKM Hospital, will moderate this session, and I will also be there. Dr. Anish, you just see the screen, read it out, and wait for the next question from the analyst.
Yes, Anish, please.
Yes, good morning to all of you, sir.
Yes.
Yeah, Anish, just read this scenario.
Yes. A 65-year-old gentleman underwent exploratory laparotomy for peptic perforation. On POD 7, there is a serosanguinous discharge from the wound. How will you proceed?
Tell us the scenario, how will proceed.
Sir, this is a 65-year-old gentleman which underwent the exploratory laparotomy for peptic perforation. On POD 7, there is a serosanguinous discharge from the wound. Sir,
so what is your first thing you will think of?
Sir, as it is a post-operative day 7 and there is a serosanguinous discharge, so sir, first I will think of sir, wound dehiscence.
Okay.
Yes, sir. And
so,
sir, yes, sir.
A serosanguinous discharge is the hallmark of wound dehiscence, or there may be other causes?
Sir, serosanguinous discharge is a hallmark, sir. Yes, sir. Actually, sir, it is on post-operative day 7. And
okay, you have said one. Dr. Basu is asking, is there any other possibility of such discharge in the wound in the 7th post-op day? One is yes, a vast abdomen, definitely. What else? Don't be focused on one situation only.
Sir, anastomotic leak maybe.
Yes.
And anastomotic leak, sir. And sir, surgical site infection, sir, maybe.
Yes,
yes, surgical site infection also you have to think, right?
It's not anastomotic leak, it's a reperforation. Reperforation of the closure.
So how will proceed now? Yes, as you have written.
Sir, I will, sir, there is a serosanguinous discharge, sir. I will first look for the general condition of the patients.
No, Anish, I always said, in such the question that was asked, always keep in mind that you need to know some more thing from the patient. So it's not general examination of the patient. You have to ask some more questions to find out what may be the producing factor for this patient to have the burst abdomen.
Yes.
And then you go for examination. First, think of something else. You are given only one symptom, that he has serosanguinous discharge. What else you would like to know from this patient about his status on the 7th post-op day by asking some questions?
Sir, first I will ask for the patient's details and when he, condition of the patient when he presented, and time duration when the he went for the operation. And sir, any other pathology, we look for the operating notes.
No. Before that, 65 gentleman.
Any
diabetes. Yes.
Yes, sir. Any comorbidities, any sir, history of jaundice, history of anemia, history of hypoproteinemia, and sir, history of any chronic obstructive disease, chronic respiratory disease. And then, sir, I will go for the operative findings.
Yes. So some points on history is a very important to ascertain the underlying cause which may cause burst abdomen, because these will be recurrent. These will be persisting even in the immediate post-op period of your burst abdomen management. So these are very important. So what you said, operative history. Yes. What operative history is important?
Sir, whether it is an emergency or
it's emergency. It's written on the face.
Yes, sir. Sir, and sir, hello.
Yeah, you're audible.
Sir, am I audible? Yes, sir.
Yes.
Yes, sir. And sir, whether, sir, this is a perforation, sir. I will look for the whether there is a peritonitis or not. The patient intraoperatively.
See, the first thing you have to ask and define that if there is any straining factor for this
Yes.
vast abdomen. Most of the time, there is some straining factor for which the vast abdomen occurs, and you see there are some patient factor you have to ask from the patient, and the other factors like the surgeon's factors like and the materials which are used, that is different. But if you do not minimize this straining factor, this vast
Yes.
abdomen may again occur. Okay, just a minute. Please continue.
Yes, sir. Then, sir, first we will ask for the staining factors like, sir, patient
You have
has
done.
any.
You have done that. That is done. Now you said operative.
Sir,
You have a very good
have,
operation note. You have a very good operation note about this patient. What are the things you like to look for in the operation note?
Sir, I will look for the suture material used. I will look for the technique of the closure of the fascia or abdomen. And sir, I will look for whether drain has been given or not. And,
the resident has given a very good operative note. So you have talked of few of these things.
yes.
How suture material affects the outcome?
Sir, there is a if absorbable suture is used, there is a more chance of the burst abdomen.
You cannot use the blank statement now. Most of the time now you are using a delayed absorbable suture, which is a very popular suture now.
Yes.
So don't use this term bluntly. Don't you close the abdomen by using a PDS?
Yes.
How long it maintains tensile strength? How long a PDS suture maintains tensile strength?
6 months, 1 year.
Yes. The end of
Hello. Hello.
which loses strength early.
Hello, sir. I haven't understand your question, sir. Hello.
You don't understand?
No, sir. I haven't heard your question, sir.
Makunda, you are disconnected.
Oh,
So please repeat your answer, please.
okay. You said absorbable suture has higher incidence of development of burst abdomen. What I'm saying is, you just don't use this term absorbable suture only, because nowadays you are using PDS suture,
Yes.
which is a very good delayed absorbable suture, which can maintain tensile strength even up to 6 months.
Yes.
And that is a critical period of the wound gaining tensile strength. And now more and more you are using PDS suture. So don't use some sutures like CADCAT or polygalactin, which loses tensile strength by end of 30 days. Okay, so definitely non-absorbable suture is preferable. But now with the advent of PDS, we are using this suture. That is also a good suture. One is suture type. What else is important?
Sir, incision.
Yes.
And sir,
What incision give in a patient a peptic perforation? What is your preferred incision?
Sir, midline incision.
Yes. So how it affects?
Sir, midline incision has got more chance of burst abdomen.
So you know that, because but advantage of midline is what?
Sir, quickly, sir.
Quick access.
And,
quick access. You can easily extend. And this is a versatile incision. So you cannot avoid midline incision.
Yes.
You cannot repair a peptic perforation by using a transverse incision. The lavage will be difficult.
Yes.
Okay, what else? Do you measure the suture length at the end of your operation?
Yes.
How it is important?
Sir, the length of the suture material should be 4 times the length of the wound, as per Jenkins.
Okay.
So what is the guidelines nowadays, the closure of the abdomen, the American Hernia Society or European Hernia Society?
Sir, en masse closure of the Abdomen.
What do you mean by en masse closure?
Sir, closure of the fascia and rectus sheath and mass, sir, means sir, peritoneum and that. Together,
Fascia means rectus sheath, fascia. There are different things.
Sir, anterior and posterior rectus sheath together and.
Okay. What about peritoneum?
Sir, nowadays, sir, peritoneum closure is not recommended.
Peritoneum closure is not recommended. Is there any advantage of closing the peritoneum?
Sir, no.
Okay. So in some papers it is said that the peritoneum closure produces less adhesions, but in RCT it is not proven. Later on. Now the suture length is 4. Yes, 1:4. And then the bite size?
Sir, 0.5 centimeter.
0.5 centimeter from?
Sir, between the edges and between the two suture.
Continuous or interrupted?
Sir, continuous.
Continuous. So then said it again. You said in a guidelines like that.
Sorry, sir.
You again said the guidelines in total.
Sir, I have to.
So you are answering part by part. When I am asking, you are answering. That is not the way. You just said what is the ideal method of closing abdomen, midline laparoscopy.
Sir, ideal
you
method
talked of suture material. You talked of suture material. You talk of the technique of closure, either continuous or interrupted.
Yes.
You then talk of the bite from the margin and consecutive distance.
And also the suture, you have already said suture length and the suture diameter also. Everything they have written clearly.
Sir, the abdomen is closed in mass with using a non-absorbable suture.
Why non-absorbable? Professor Shah, they say repeatedly, delayed absorbable. Yes.
Yes, sir. Sir, using delayed observable suture, and the distance between the two suture is 0.5 centimeter, and distance between the edge from the suture is 0.5 centimeter.
What is the diameter? You choose the first. You have to choose the diameter because you ask the sister, give me such and such suture to me, right?
Hello, sir. Your video has been paused, sir. Hello.
Yeah. Dr. also asks, what is the thickness of the suture? For a midline abdominal closure, what should be your thickness of the suture by 0? 2, 0, 1, 0, 1. What do you prefer?
1, 0, sir.
1, 0. Why for a midline? 1 should be a reasonable thickness of suture. How does a suture thickness affects
Actually, he should tell if he said that they say 1, 0, then he have to ask for said their loop PDS, because it is written that the 0 loop, that means actually 1.
That makes it 1, yes.
Yes.
Two suture makes 1.
So Anish, even now you have not said the exact guideline. You are always answering part by part. Why? You have not. This is the basic things, because you are the resident, you are doing the emergency laparotomies, and you have to close the abdomen in a proper way in every case.
Sir.
Okay. So this is the thing. That means small bite closure, fascial closure, definitely. Peritoneum is usually not included. 0 loop PDS is usually preferred suture, and as you said, a 0.5 centimeter from the margin and between the two bites. So small bite, right? Now this is the preventive method. Now your case is you are suspecting burst abdomen. So what is your clinical feature of the burst abdomen? That means what you will see now going to the patient. As you said, firstly, you will first look the general condition. Okay, local examination. Tell me.
Yes. Sir, I will look for the any abdominal distension.
Hmm.
Patient having any guarding or rigidity patient have or not.
Hmm.
You remove the
And,
dressing, na? You'll
yes,
remove
sir,
the
we-
dressing, I feel.
Yes, the first thing you have to remove.
Yes. Yes, sir.
After
Okay, fine.
managing the
You assess
general
the
condition.
distension, rigidity, fine, but also look at the wound. What in the wound is important.
Yes.
Sir,
Already it is said there is serious sanguinary discharge.
sir, we will put our gloved finger inside and look for any.
No, don't try to put the finger inside initially. What you look for?
Sir,
You just palpate. You see, if there is a vast abdomen, you will find that deep to the skin, you can feel the gut.
Yes.
You do not just poke the skin, and if it is intact, don't poke that in straight away. In some situation, what is concealed vast abdomen, Anish? What do you
Sir,
mean by concealed vast abdomen?
sir, concealed burst abdomen when the deeper layer of the wound gets separated, but the skin is not separated, and the
Yes.
gut
So
loop
that
can be
is as
felt.
good as a vast abdomen. So in that case, in the ward, don't try to open up the skin in the ward, because you can easily make out that gut is lying deep to the skin.
Yes.
Okay. And then, and second situation is you open up the wound and you can find the omentum and gut is seen.
It's popping out. Yes.
Yes.
Now what to do?
You have diagnosed a complete dehiscence of the wound in the ward on 7th post-op day in the late hours at night. And then what to do?
Sir, initially first we resuscitate the patient if patient is hemodynamically
Good. Don't
unstable.
forget that. That is most important.
Yes.
So you have to assess the patient, resuscitation followed by wound care.
Wound care. And then we, sir, go for the exploratory laparotomy.
When? Next day, 9 a.m.?
No, sir. Quickly, sir.
Yes. So
As
this is
soon
surgical
as-
emergency. You should
Yes.
resuscitate, and side by side, you should go for the proper management.
So can we do the conservative therapy in the vast abdomen?
We can do the conservative therapy, sir. If the patient's condition is vitals is stable and there is a no intra-abdominal sepsis or no intra-abdominal and the
You are
gut
saying the
is
reverse. If that is there, I will take the patient to theater early. If the patient is stable, if the intra-abdominal condition is suitable, this is a high time to take the patient to theater.
primary abdominal.
No. You talk of the, Dr. Basu asked, when you can do conservative. If the patient is stable, intra-abdominal conditions are all favorable, is ideal time to take the patient to theater and repair it. Otherwise, you have some situations where you cannot take the patient to the theater.
And also, if there is ongoing infection with peritonitis, this is the situation where you do the conservative. Otherwise, the redehiscence is likely to occur. So, when patient condition is okay, the abdominal sepsis is not there, you have to primarily close the reclose the abdomen.
So if you keep the abdomen open, that is a situation known as open abdomen. So that is another a big entity for management. You understand?
Yes.
Management of open abdomen.
Open abdomen.
Okay, we'll come to that later. So this is a patient and you have started resuscitating, but you find that patient has got some evidence of intestinal obstruction in the immediate post-op period. He has got pain abdomen, distension, he was vomiting, and that resulted in this vast abdomen. He has some evidence of intestinal obstruction. Will you think of doing conservative or you go for early surgery?
Sir, I will go for early surgery.
Yes. What surgery? Patient on table.
Sir, re-exploration, and I will re-explore the abdomen. I will look for the site of obstruction and proceed accordingly, sir.
Gut are all distended. And now you think that you cannot close the abdomen, which might result in abdominal compartment syndrome in the post-op. What is the solution? You got my point? Patient has got, because of obstruction, patient has got gross gut distension, and you cannot repose the whole gut in the abdomen. And if you do it forcibly, it might result in internal hypertension, the post-op period. What's the alternative now?
Sir, we pack the abdomen and then we go for the open abdomen management. There is no option.
Pack abdominis. Where did you pack?
Sir, we pack with a gauge piece or a mop, sir.
No.
The temporary, sir, we go for the temporary abdomen closure. Vacuum pack or sir, negative pressure wound therapy.
Can we use the mesh in this situation?
Yes, sir, we can use mesh, sir.
Where do you fix the mesh? Where do you fix this mesh? This was an abdomen which was not closable. There is a wide gap. So here, one option is keep the abdomen open, number one. Second is you can do a temporary closure by placing a mesh. And I am asking, how do you place the mesh?
Sir, we first put a polyethylene sheet, sir, over the gut, and then we place the mesh. Fits with the lateral abdominal wall, sir.
Yes. So the mesh will bridge the gap.
Yes.
This mesh will bridge the gap and avoid a polypropylene mesh. If you have the facility and you got a composite mesh, that is a better mesh to put in, because in that case you need not put a polyethylene sheet over the gut.
Or you can use the absorber mesh like vicryl mesh sometimes. So no, this is another situation when you cannot close the abdomen. When you close, you can close the abdomen. So what is your ideal suture, ideal bite, everything is you tell. I think you have seen the vast abdomen closer.
Yes, sir.
Yes. Now
sir, ideal suture.
What is your what is your method of closure of the abdomen in case of vast abdomen?
Sir, all the layers of the abdomen is approximated by interrupted through and through suture using a delayed absorbable or non-absorbable monofilament suture, sir, with bite distance of, sir, 1 centimeter.
1 centimeter.
1 centimeter is too close. And what is that suture called as? If we apply all layer closer and put a rubber band on that, close with interrupted suture, the gap of,
tension band suture.
These are called retention suture. Yes.
Retention suture.
So that is one technique. How else you can close apart from these retention sutures? Because now there are studies. Now there are studies of a continuous closure, interrupted closure without retention suture or retention suture. So what is the inference of different technique of closure?
Sir, other techniques, sir.
I said it can be a continuous layered closure again. Yes. It can be a interrupted closure with retention sutures, or just a simple retention interrupted suture. What is the difference in outcome?
Sir, sorry, sir.
I said there are different techniques. It is now we have a lot of publications. We see that that this technique of closure is not very important in subsequent outcome. It has been observed that the incidence of incision hernia, the most important outcome measure in this group of patient is a development of incision hernia, which can be as high as 40%. Okay, so it is observed that whatever technique you use, the rate of incision hernia is not minimized. And the retention suture with these long bites does not prevent development incision hernia in the post-op period.
Yes. So whatever closure technique you are describing, sorry, all are these static closure technique. So the EHS recently they will publish soon, very soon. They have already prepared the guidelines. So they are now recommending for the dynamic closure, and only the dynamic closure can prevent in lesser number for the incision hernia. But dynamic closure is a system. It is not available everywhere, and it is very expensive also. So dynamic closure, we only know dynamic closure by seeing the videos and all those things, but we have not used and we have not seen in our eyes. what is dynamic closure. So dynamic closure is like that. You just put the sutures away from the margin, at least from the 3 centimeter from the this wound margin, and slowly close the suture. Slowly close the suture over this traction part, and covering the gut with a sheet, like as you said, that this plastic sheet or this polypropylene sheet like this. So polypropylene sheet name. So this is the plastic sheet, which which can be used as a covering, and over the covering you put the suture like this, and slowly you tie up, so tighten, and then the abdomen is closed. So this is a system. So this is one method they are recommending, and the other advanced method like component separation and plastic surgery like skin grafting, they are not recommending at all. They are said that yes, expertise can be sought if these measures needed. So you always think of, you just read in literature and see the videos of the dynamic closure, because nowadays all static closure, all types of static closure have the same incidence of incisional hernia, as the Professor Shah said, because that is the most important complications of vast abdomen in later date.
You have done a repair. In the post-op period, how will you diagnose the patient is developing intraabdominal hypertension and then a consequence of compartment syndrome? How will you diagnose?
Sir, patient is having abdominal distension and sir, reduced urine output.
Compartment syndrome patient may not have abdominal distension. Try to understand. You have packed this everything and then sutured it. So abdomen is tight. How will you diagnose that patient is developing intraabdominal hypertension?
Sir,
what will happen? If you have abdominal compartment being a high pressure, what is going to happen first? It compresses which important structure?
Bladder, sir.
Not bladder. Which is more compressible structure in the retroperitoneum? IVC.
Kidney. IVC.
IVC and the renal vessels. So what is going to happen? The first thing to manifest will be low cardiac output. So patient will have tachycardia, patient will have hypotension, patient will have oliguria. And then how can you measure the intra-abdominal pressure? By simple measures in the ward. How can you measure intra-abdominal pressure in the ward? With simple maneuver.
Sir, bladder catheterization. Bladder.
Yes. How do you measure the pressure? How will you measure the pressure? By using the Foley's catheter. You instill 50 ml of saline through the Foley's catheter and connect this to a manometer, taking 0 at the mid-axillary line. So that is the pressure you can measure on the bedside. What is normal intra-abdominal pressure?
Sir, 10 to 12.
8 to 10. More than 10 and more than 12 is taken as internal hypertension. What is the post-op management? You have repaired the vast abdomen. What is the post-op management in this patient?
Sir, proper wound care, sir. And then we look for the patient should not develop any cuff or straining factors.
What do you advise in the post-op sheet?
Sir, normal, sir.
Hefty perforation patient repaired. Patient has some abdominal distension pre-op. So,
sir, nasogastric tube and
yes, nasogastric decompression. Then,
sir, catheterization. Sir,
yes.
Proper urine input-output monitoring.
Yes.
And sir, antibiotics and
yes, definitely antibiotic you have to give, because one of the important cause for failure in these patients are SSI. So you have to give the patient antibiotics.
And sometimes, if needed, assisted ventilation is very important to reduce this strain.
And you should not forget about the nutrition. 7th post-op day, patient was on IV fluids, and then you are having a vast abdomen. You should also consider the maintenance of nutrition in this patient. And then other general care, chest physiotherapy, taking of for care for DVT. Okay. What are the important technical factors which can cause vast abdomen in the post-op period? technical, I mean surgical factors?
Sir, repair under tension.
Yes. So it should not be under tension. Number one. Number two.
Sir, missing of the any obstruction, sir, or any intra-abdominal collection, sir, which can be.
That is not a surgical technique. I'm talking of surgical technique in the closure. You have talked of something. Just summarize that.
Sir,
One is it should not be under tension. Number two, that means you should not pull the thread too much.
yes.
What happens if you're giving continuous suture and your assistant is pulling the thread too much? What is going to happen?
Sir, cut through. Suture.
Apart from cut through, what happens?
Sir, blood supply will.
Yes.
Very
So it will
tight
cause
suture will
ischemia.
cause a
If
ischemia.
you pull the thread too much, it will cause ischemia of the margins, and this will cause ischemic necrosis of the margin and lead to failure. What else? Then, as I said, a continuous suturing is not obsolete. You can do continuous suture, but it is said that the interrupt suture causes less incidence of post-op hernia and bust abdomen. But continuous suture is described. You can do that. Then again, that part you said is the consecutive distance between the bites and bite from the margin. And then you should consider about the suture material you're using. It should be a delayed absorbable or non-absorbable suture. And then you should at least use 4 times. Now people are saying even up to 5 times.
5.
It should be at least 4 times. And now people are saying it will be 5 times the suture length and the versus the wound length. Okay, Dr. Basu, anything else?
Yes, yes, yes.
So always keep in mind, Onish, that whenever a such scenario is given ward round, you should
Yes.
always keep in mind there are something to be asked from the history for evaluation,
Yes.
and then examine the patient, and then wait for the examiner question how you like to take you. Don't jump to examination of patient whenever such scenario is given. The history is important to assess the patient's previous condition, the assess whether he has got any post-op complications like cough, any evidence of internal obstruction,
Vomiting.
any fever suggestive of intra-abdominal sepsis. So these are all important. You can assess from the history part. And then examination is simple. Examination is examination of vitals and the local examination. Okay, and the management will be based on the patient general condition.
Yes. Okay, any question from the students? Any question to Anish?
Sir, I want to ask one question, sir.
Yes, yes.
Manage an open abdomen. If you are in a situation that you cannot close the abdomen, you can keep the abdomen open, and instead of applying a mesh, you apply a plastic bag suture to the either end of the wound, so that you can do the dressings and you can take the patient subsequently to the theater for early closure. So if you put a bag on a bag, now there is a concept of early abdominal closure. You don't, if you keep the abdomen open, the option is you can apply a vac system that causes early wound contraction. Second is you can go for a dynamic closure where you just gradually pull the margins and then take the patient theater when everything is conducive. Bogota bag is one option. Yes. What you are talking of, you are thinking of putting a mesh on either side of the wound, bridging the gap. You can bridge the gap by simply plastic a Euro bag.
Euro bag.
And also wound manager can sometimes help if there is a lot of guts are out.
Yeah. Any more question?
Sir?
Yes.
Hello?
Oh, yes.
Sir, open wound management is a part of conservative treatment.
Yes.
Yes,
Yes.
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 Okay. What is far and near technique? You see, this is a technique described by AIMS group, where they are claiming that, you see, there is a concept of seesaw effect. If you are using a continuous vertical suture, and if the patient is coughing, has got abdominal distension, there is tension at the suture bite point, and in between there is normal tissue. So there is a seesaw effect, and these points usually cut through. That's why people are recommending that you go for interrupted suture. The seesaw effect will go. And now they have studied that if you are applying an interrupted suture within far and near technique, that means you start from the far on one side, come near on the other side, and then take an exit far from this side and near on the other side. And if you tie this suture, they said that the wound strength is better with this type of suture. So this is the far and near technique suture. But again, you cannot avoid the patient factors. You cannot avoid the post-op factors. Technically, this is claimed to be a better technique of closure in abdominal wound. That is one technique. But other factors are important.
Excuse me, sir.
Yes.
Sir, whether we can temporarily close the skin, allow the incisional hernia to develop, and later we can take care of the closure, sir.
This is one technique, just keeping the skin closer. But point is, if you have a situation in the abdomen which are not conducive, in that case, even deep to the skin, there may be gut-related problems. So only simple skin closure is not a recommended procedure for burst abdomen management.
Thank you, sir.
Okay, thank you.
Okay, sir. Thank you.
What about the 32?